Welcome to the Caregiving Wisdom Series. This is all about featuring experts from across the nation who bring both a personal and professional wisdom to so many different aspects of caregiving. I'm Deb Kelsey Davis, and with me is Kelly Johnson, busy letting a lot of people into our meeting. You're coming in by droves here. We're so happy that you're here. We're the co-founders of Nourish for Caregivers, and we're so excited to bring the series to you. If you haven't already noticed, in the lower right-hand side, there's a chat box. As we're moving throughout, if you have a question that comes to mind, please type that question in the chat box. We're going to use the chat box as a means for taking your questions and having Aimee answer those questions. So we know your time is precious, and we know that you've made a choice to spend an hour with us, and for that, we're so very grateful. So what makes this series different from others that are offered to caregivers? Well, what makes this difference is the fact that we incorporate the spiritual aspects of our lives, our faith, along with the practical and the emotional aspects of each topic. All right. You're catching a glimpse of Aimee, and you're going to get a better glimpse of her in a moment. Let me introduce Aimee Gustitis. She's going to share her wisdom on dispelling fears surrounding hospice care. Aimee advises caregivers and their loved ones on basically how to comfortably and confidently age in place. Her nursing and legal experience, wow, Aimee, I always am amazed by that, encompass over a decade of serving patients and their families in long-term care home, hospice, and hospital settings. After years of counseling caregivers and their loved ones, Aimee started her own care management agency to bring a wealth of clinical and legal and practical experience to her private caregiver clients. She also facilitates several caregiver support groups. If you've been on house calls or if you're in the Philadelphia area, you've probably seen Aimee. Aimee frequently addresses challenges such as, how can I help my loved one age at home rather than move them to a continuing care community? Or, if you've ever thought about this, I feel overwhelmed. Have you ever said that to yourself? And resentful by the constant care and changing needs of my loved ones, to name just a few. Aimee authors caregiver advice columns for several regional online publications. Aimee is coming to us, as I mentioned, from the Philadelphia area, where she's a member of the Archdiocese of Philadelphia Speaker Board, and she frequently presents on elder care topics of interest to audiences both large and small. Aimee believes it's an honor to collaborate with families and their loved ones, especially in the time of need. So, before we begin,
let's spend a minute experiencing one of the most powerful and healing forms in our world today, prayer. Prayer not only affects the heart and spirit, but it also impacts the physical body. Caregivers often tell us that prayer is like medicine, so we share a short prayer with you tonight. A caregiver's prayer. Lord, provide me the strength I need to face each new day. Give me the patience when I feel my frustrations rising. Be the wind at my back to gently lift me and keep me moving forward. Open my eyes to see the blessings before me. And as my head touches the pillow tonight, remind me that whatever tomorrow throws at me, I have you to help me handle it. Amen.
Amen. And with this, we're now going to start hearing from Aimee, and I'm going to stop sharing my screen, and in just a second, you'll be able to see Aimee on her screen.
Well, good evening, everyone. Thank you, Deb and Kelly, for that lovely introduction. It's a pleasure and an honor to be here tonight, especially to speak about this most sacred topic of hospice. And my hope tonight is that I can dispel some fears and answer some questions and give you a renewed sense of hope that hospice isn't just the end, that it's just the beginning of the journey that you have in terms of carrying your loved one towards the gates of heaven. And that we here at Nourish are honored to be able to be a part of that journey. So let's talk about dispelling hospice fears. The concept of hospice can be upsetting. It oftentimes creates fear, and it can also be a precipitation to hopelessness. can just make people feel weary and worried that, oh my gosh, just when I thought things couldn't get any worse, now we're starting to talk about hospice. But I'm here to share with you that there's many things to be hopeful about regarding hospice. And one of them is that hospice can empower your loved one to age in place at home. By bringing the hospice team in, you're bringing in the practical and emotional and spiritual support that you might not otherwise have if you were to go about this alone. And it gives people a renewed sense of, okay, I can do this once you're surrounded by a team of people who are supporting your goals. Hospice is hopeful, and the dying process can be a beautiful experience. A lot of times people associate hospice not only with death, but with giving up. And it's really quite the contrary. Hospice allows families and friends to be able to savor the time they do have with their loved ones. And that term savor really comes into play when people start to think about, is it better if my loved one goes back to physical therapy or goes back to rehab or continues with their course of chemotherapy? Or perhaps it might be better just to allow them to be comfortable in the comfort of their own home and be surrounded by people they love. And oftentimes families, in hindsight, reflect on that and they say that they're so very grateful that they had that time to be able to focus on their loved one and to really enjoy being a spouse or a daughter or a son or a child, and to really just relish the role that they have with that person, as opposed to be concerned with taking them to doctor's visits or having procedures that maybe were no longer being helpful. And I'd like you to take a moment just to think about yourself as a caregiver, and that in our beautiful love of the Christian belief system, we literally believe that we are carrying our loved ones to the gates of heaven. And that's something that's very unique to caregivers. It can make it incredibly painful, but it also can be an incredibly graceful and gratitude-filled experience because you actually get to be with your loved one during this most intimate time. And even though it's difficult, through the power of the Holy Spirit, we're here to share with you that it can be a time of hope. And it's with these thoughts in mind that we continue. So I'd like to start off when I discuss hospice to talk about the finances, because that oftentimes causes people stress. Hospice accepts patients who are on Medicare, Medicaid, or private insurance. It is covered by Medicare Part A, and there are no out-of-pocket costs, so that you don't have a copay in terms of applying for hospice or receiving hospice. Hospice also covers diagnosis-related medications or medications related to comfort and end-of-life symptoms. You'll be given routine nursing, social work, and chaplain visits, as well as home health aide personal care assistants that can come into your home or loved one's place of residence and bathe your loved one or perform light housekeeping duties for up to 2 hours a day. And all that, again, is covered by insurance. They also supply skincare and incontinence products, which, as you know, can be quite expensive. And they also deliver and set up any durable medical equipment that your loved one might need. For instance, a hospital bed, hospital bed that would have the controls so that the head of the bed can go up and down, or maybe a low air loss mattress so your loved one doesn't get bed sores, oxygen tanks and tubing and a concentrator, wheelchairs, and other related items. And again, just to reiterate, it seems people want to know what the catch is, but it is all covered by insurance. So I like to go over some pre-hospice scenarios with people so that they can get a sense of if they're wading into the waters of hospice. And one analogy that people can identify with is being on the medical merry-go-round. And by that, I mean that you continue to go to doctor's visits, or your loved one has procedures or receives medications, and you really don't see any physical progress or improvements. And that can be very disconcerting and just disheartening to everyone involved. You might be getting ready, or your loved one might be getting ready for hospice if you're starting to feel overwhelmed and resentful by the constant care and changing needs that keep happening. You might catch yourself thinking, I'm not sure how much longer I can do this. And that's very common. And that's nothing to be ashamed of. It's just a sign that you need some help and that hospice might be an option for you. We also look for infections and falls resulting in repeated hospitalizations over the past year, unexplained weight loss, urinary and fecal incontinence, ongoing restlessness, roaming and/or hallucinations, verbal and physical aggression or agitation, and nighttime restlessness and frequent falls out of bed. So you might see your loved one in one or two of these scenarios, or maybe not at all. Or maybe you might be thinking, oh my gosh, my loved one, I can check all of these boxes. And again, it's just more of a sense that you get to understand what you're looking for in terms of the decline. Because obviously not everyone's qualified for hospice. The gold standard is that 2 doctors agree that your loved one has 6 months or less left to live. And that's a prediction. That's not a definite statement. And that there are many people who stay on hospice for years because they requalify at the end of the months. So there's no fear in terms of being on hospice and you're going to have it taken away from you necessarily. Some people actually get better while they're on hospice and they graduate. While other people, they find a new normal, and all of a sudden they're not going to all these doctor's visits, or they're not having procedures done, and they're just focusing on being comfortable, and they start to find sort of a plateau, if you will. And that's the time where your loved one starts to really savor being and thinking, wow, I'm really glad I made this decision, because now I can enjoy my loved one as opposed to always be worrying about test results or blood work or whatever else that is happening in your loved one's life. So I made a flow chart to try and help walk through what happens in terms of hospice evaluation and admission key steps. You'll see over on the left where I have pray first. And that as Christians, we can all identify with the concept of let's ask for God's direction, let's ask for his discernment, and then we can go about making our decisions. Now, if you're anything like me, there's plenty of times when I make decisions and then pray that God will get me the outcome that I want. So it's not an opportunity to feel bad or feel guilty. It's just something to think about when you are considering something that's sacred and obviously a very important decision. So initially, you're going to want to consult with your loved one's attending physician if they're in a hospital or in perhaps a nursing home, or you're going to be wanting to talk to the primary care physician about the concept of hospice. And what you would be doing is asking the physician, do you think that my loved one is hospice appropriate? That's the term. And the physicians will then go ahead and do a review, and sometimes they can answer you immediately. Sometimes it might take a little bit of research. The other alternative is if you have a hospice provider that you've been talking to, that hospice provider can also contact the attending physician or primary care physician for you and get what's called a physician's order. So now we're in the middle column and under physician 1, where we obtain a physician's order for a hospice evaluation and treatment. And this is where the part comes in where there's 2 physicians that must agree that your loved one is hospice appropriate, meaning that they have 6 months or less likely to live. After getting the physician order, you would then meet with hospice representatives and sign consents. These consents can be signed by the power of attorney or by the patient themselves. They can be signed in a hospital or in a home setting or in another healthcare setting. The goal is to make things comfortable and convenient for you, and hospices generally work with families to make that happen. And once you've had a chance to learn the background of hospice and what you're signing on to, you'll go up to the final column in the right-hand corner, where you'll actually have a nurse complete an assessment at the patient's place of residence. That, again, that residence could be in your daughter's home, it could be in your, uncle's home, it could be in an apartment, it could be in a hospital, it could be in a nursing home. It's the hospice, the care will come to you no matter where you are. Following that nursing assessment, the hospice nurse then presents that information to physician 2, who is a physician related, a hospice physician, who is related to the agency that you're working with. So at this point, this physician would have to concur with the first physician that your loved one is in fact hospice appropriate. And should that occur, the next step would be to admit your loved one or yourself to hospice. So you can see it's a little bit of it can be a little bit complicated, but if you just take a look and step back about the prayer and consulting with your physicians and then meeting with hospice, and then hospice will do most of this work for you. You're not expected to coordinate this or make copies of paperwork or even find the paperwork. It will come to you in a booklet and all the information will be explained to you. And there, even if you do choose to meet with hospice, there's no obligation that you have to sign up. You're not penalized if you sign up or don't sign up. And if you go through these steps and you find out that your loved one's not quite ready for hospice, sometimes it's a blessing that you've already taken this step. Because when the time comes that your loved one is hospice appropriate, they already have a file and they already have your information, and that makes the admission process that much smoother. So following hospice admission, you'll be assigned an interdisciplinary team, or an IDT. This team is comprised of a nurse case manager, social worker, a chaplain, and a physician. Generally, these IDT teams meet bi-weekly, and they review each patient individually, and they look to see how things are going, what can be done to improve things, maybe where do things need some tweaking. And it's a good check for families because they know that the team is actually meeting generally in person, if not, over the phone, and your loved one's getting a thorough review at least every 2 weeks. Routine visits from these professionals and from a home health aide will be scheduled. Initially, you might have a nurse come once or twice a week, and you might have a home health aide come 3 times a week, but you are allowed to have, the benefit does cover home health aide 7 days a week for up to 2 hours. And the nurse can come any time of day or night. Hospice is on call 24/7, and that you can call them for whatever reason, even if you're just scared or, the middle of the night, you're having doubts and worries. They're there to provide not just the practical clinical support, but they also want to hear from you emotionally and spiritually. And then after choosing hospice, you might decide, wait a second, you know what? I do want to go back to my chemotherapy, or I am going to get that stent placed, or I'm just not comfortable with hospice. I'm really feeling leery about this. That's absolutely okay. All you need to do is just say, you notify hospice and say, I'm going to withdraw from this, and I'm going to go back into the traditional system that I was in terms of insurance. If you want to go to the emergency room, that's fine. Because generally your hospice is your 911. So most people who are on hospice don't go to the emergency room unless there's something truly, like, for instance, if somebody fell and broke their arm and they needed to get a cast on their arm, that certainly would be covered if the person wanted that to be done. But generally people who are on hospice don't go to the doctors anymore. And sometimes that can make people a little bit nervous. But remember, you have the care coming to you now, so you don't have to go to your primary care physician because the nurse and the doctors will be coming to see you. So going forward, I like this quote, and forgive me, I forgot to attribute it to the person. The dying process is a sacred time. It's a final season to seek closure in this life and prepare for the next in the hope of sharing in Christ's resurrection. As you enter into this season with your friend or family member, ask God to accompany both of you. And this is absolutely true. This is just an amazing opportunity for people in general, but especially if you're Christian and if you truly believe in the power and the resurrection of Jesus, that we don't believe it's over when we die, and that our spirits will one day be our spirits will be resurrected for sure in heaven, but also too that our bodies will be resurrected. And what more beautiful time to draw close to the Lord than in our closing season of life. And also to have this opportunity where some people might say, well, what's the point? Why can't we just hurry this up? But there's a sacredness to the dying process, and there's beauty to it. And there's many, many gifts that come from participating in the care of someone who's dying. And it's amazing, the graces, the conversions of heart, the forgiveness, the fences that are mended, and all sorts of good things that can come out of being a part of the end of someone's life. So even though it can be scary, of course, there's also many good things that can come from it. And if you'd like to read more about some spiritual resources, you can look at Focus on the Family's website, the Catholic Health Medical Association, or the Catholic Medical Association websites. There's also the National Catholic Bioethics Center, and nourishforcaregivers.com also has a wonderful resource page with lots of information. A lot of these sites also do have power of attorney documentation, advanced directives that are written specifically with a Christian version of it, if you will, so that you feel like what you're looking at is something that you would be in agreement with morally. But any attorney, should you choose to sit down and talk to them, certainly can guide you along that path as well. So in closing, for the presentation, I thank you very much for your time. And please take heart in the fact that even though that it can be fearful and frightening, there's also many blessings that can come from a peaceful and beautiful death. Thank you.
So now we want to take questions, and I see Sonia has a question. Sonia's asking, are all hospice programs the same?
Great question, Sonia. Essentially, yes, in terms of the United States. So I'm not going to speak to hospice outside of the country, but hospice is, as I said, a Medicare benefit, meaning that it's like a federal benefit, if you will, and that it's not state specific. Unlike your power of attorney or your advance directive or your estate planning, which is state specific. But all hospices offer the same services. It's just that different hospices might have a different culture. Some might have inpatient units, and your loved one might have very complicated or very difficult to manage symptoms, so that might be attractive to you. Some might be more focused regionally, and they have a good rapport with people locally. And a really good way to find out about hospices is just to ask people. If your loved one's at a care community and you can ask the nurse there, hey, what hospice would you use? Or, it's not such a secretive, treatment, if you will, anymore. People are starting to be more open about it. And it is very common for people to say, well, what hospice did you use? And to get a good amount of feedback from your friends and from your circle of influence.
Sonia had a follow-up question with that was, are there other religions that have hospice? And I think maybe the question also ties into, is hospice tied in with a particular religion, a hospice program?
Thank you, Kelly. Hospice is not Christian per se. Hospice is an all faith or no faith, if you will, program benefit. It's not necessarily affiliated with Christianity or Judaism or Hinduism or anything like that. And each hospice has their own group of spiritual leaders. So they do have, Jewish leadership and people who maybe are more, if you will, like some people say I'm more spiritual than religious. So they'll have opportunities for things like maybe Reiki or massage therapy or things that are more holistic rather than, religious, if you will. And the hospice will tailor their care plan to anything that the family needs. So they don't advocate for a specific religion. They just advocate for what it is that the family wants. my reason tonight for bringing it up is because Nourish is a Christian ministry. So that was why I was specifically speaking about it from a Christian perspective.
Maybe the follow-up question with that might be Mimi's question, how do we find the Catholic or Christian culture hospice? So often the caregivers, are not aware that there is such a thing.
Well, I think that it's important as leaders of ministries that we educate ourselves. Hospices are more than happy to come out and do an in-service, and they can talk to whether it's your church leadership that you want to have come speak to them about it. They'll even just come to your house. I mean, they're very willing. They're all about education, and all of this is provided free of charge. And it's one of those things where once you start to talk to a hospice and you get to know the people involved with it, you start to get a sense of, oh yeah, I like the way this hospice feels like this is a good fit for me.
Mm-hmm.
So sometimes it's a little bit of trial and error. But again, don't be afraid to call up and say, hey, can I talk to a few hospices just to see what would be best for my loved one? Or even if you don't have a sick loved one, they'll still want to talk to you and just give you the education that you need.
Aimee, we have a question from Jeannie who says, I think the biggest issue is that people wait too long to bring hospice into their homes. Have you seen that? Do you agree? And what usually is the experience?
I'm glad you brought that up, Jeannie, because I do see that frequently. And unfortunately, because of the stereotype of hospice, people think that their loved one has to be actively dying. And because people wait, it appears that their loved one went on hospice and then they died. So people start to think that hospice caused the death, when in fact the loved one was already actively dying when hospice was brought in. So you can see how over time, as people wait a while and wait till the end to bring on hospice, those two concepts get tied together. When in fact, people's quality of life can really improve if you bring in hospice earlier. And going back to the flow chart that we were reviewing earlier, there's no harm in having hospice come in and say, you know what, your loved one's not appropriate yet, but I bet you in maybe another month or two. So there's no harm or cost to you in terms of investigating it earlier rather than later. And everyone I've ever worked with has said, I'm so glad that I brought hospice on. I've never heard people say, geez, it was too early for hospice. A lot of times I hear people say, I wish I'd done this sooner, if only I'd known, if only I wasn't so afraid. And, you know, that's part of the beauty of getting the word out, is to give people that confidence, if you will, that they're doing the right thing for their loved one.
A question that was in here was from Helene. Comfort care is another level of care. Can you talk about that, and is that paid for by insurance?
Helene, I think maybe what you're referring to is, we were just talking about this.
Palliative care.
Palliative, thank you. Totally blanking. Palliative care is another term for comfort care. Palliative care is still in the same segment of healthcare that traditional curative means are. It's just that you sort of forego some of the procedures or maybe the medications or maybe the more aggressive treatments. But you would not have necessarily the same support system with the social worker and the home health aides and all that if you choose to do comfort care. That being said, many different hospitals and healthcare organizations offer comfort care, and they can work with your family if you know, and some of it is covered by insurance. It's just not as sort of neat and clean of a picture as it is with the hospice benefits.
Mariana had a question. So if someone goes into a nursing home under hospice, is that covered? Say they broke their hip and needed rehab. So they are at the nursing home for that. But because they have other issues, they had to go under hospice to be allowed into the nursing home.
What I see, Mariana, is that people, if somebody was going to a rehab for physical therapy, status post hip fracture, Medicare would cover, generally it's up to 30 days of therapy. And after that time, if somebody wanted to elect to go to hospice, they certainly can. But the thing with Medicare is they won't pay for curative and hospice. So you have to pick one road or the other. So what I've had with some families is that their loved one is end-stage dementia and fell and broke their hip. And they're going, should I send them to rehab or should I bring them home on hospice? And that's where it gets a little bit tricky, because I like to advocate for families to bring their loved one home if their loved one could be comfortable, because it's very disorienting, especially for people with end-stage dementia, to go into a rehab and to go through all that therapy, and they can't remember what the instructions were. So it's frustrating to them to have to go to physical therapy or occupational therapy or speech therapy, only to not be able to remember what they were instructed on. So if your loved one is of sound mind and body, or perhaps in an earlier stage of dementia, and you wanted to go to rehab for a few weeks, that's fine. It's sometimes, unfortunately, it's a little bit of a game of numbers. If you're concerned about costs and being able to care for your loved one, you might want to have them go through the rehab course, and then after rehab, place them on hospice. Because once they're on hospice, the rehab isn't covered anymore. So that's sort of part one to your answer. And the second part is that, yes, hospice does go into nursing homes, assisted living, independent living. They can go anywhere. So it's not, if your loved one is in a nursing home or continuing care community, hospice is allowed in to provide the care. So for some families, it's really helpful, because it's another set of eyes and ears that are looking at and advocating for their loved one.
Jim had a question. Thank you, Jim, for this question. Aimee, what's your experience with family conflicts, especially among maybe the sons and daughters, over the decision to seek hospice care?
I think a lot of times, Jim, what happens is it's more about anticipatory grief and the phases that the family are in. For some people, they just can't get their head wrapped around that their mother or father, I'll use your example since you're talking about siblings, that their mother or father is passing away. They just can't give up on them. And that's a function of anticipatory grief. So it's very common for maybe one sibling to be saying, no, we've got to finish the chemo, we've got to keep fighting. Or another sibling might be saying, you know what, mom just isn't benefiting from this, and I really want her to come home and be comfortable. In my practice, I do calls and family conferences, and we do talk about these things. Sometimes it can be rooted in, a past wrong. Maybe somebody was the favorite child, and now they're the one that has the power of attorney, and they're making all the decisions, and the other siblings are rightfully feeling left out. So there's a lot of anger there. So what I try and do is to bring up in a constructive way, a compassionate way, where some of the grief could be coming from. And sometimes once we get a chance to talk about that, people then can refocus and go, okay, now I can go back to what's best for mom as opposed to what's best for me. Sometimes it takes a little bit of time. And I mean, the other flip side of that is that you do go into a contentious situation where, let's say the daughter is the medical power of attorney and the son's the financial power of attorney. And the daughter is saying, no, I want mom to go on hospice. And the son's saying, well, no, I don't. Well, if the daughter has the financial or the medical power of attorney, then she gets to decide. So your question is very helpful, because it brings up the point and drives home why it's so important to talk about this with your loved ones and your friends before it becomes a crisis. Because if everyone knows your wishes, then there's not much to argue about. It's when nobody talked about it and it's a big secret, and that's when things start to get sideways sometimes. And also too, since we're talking from a Christian perspective this evening, this might be a great opportunity to bring in some people from the church. A lot of the local deacons are specifically educated on Catholic bioethics and anticipatory grief and all sorts of things. So it certainly would be something to take to your church as well.
And I think that's Dabney's comment in here too, is she said, be your loved one's advocate. And she talked about her own experience about her mom being Protestant, but when they interviewed, the chaplain was a Catholic chaplain. And so their decision to have the Catholic priest come, and what a good decision that was, because of the way in which they felt like it was the right connection and the right person.
Aimee has a question specific to how is holistic hospice different?
Holistic hospice, essentially all hospice is the same. meaning that you're going to have a skilled nursing visits, you're going to have home health aides, you're going to have a social worker, you'll have some sort of chaplain if you wish. Prior to COVID, they had volunteers and music therapy. So there's all sorts of things. The holistic term that I had used earlier was more about, like, as opposed to a formal faith like Judaism or Islam or any other sort of faith tradition. That we can sort of get behind. There's a leader of that organization. We understand what the beliefs are in the afterlife, and the hospice would work with the family and the loved one to create a comfortable spiritual plan of care. But for people who maybe aren't necessarily religious but do feel spiritual, that's where I use the term holistic, because that brings in things like, maybe you want to talk more about like spirits or whatnot. I mean, again, that's not something the Christian church would advocate for. But if you're dealing, hospices are religion neutral. So they're going to do whatever makes the person comfortable. For some people that might be meeting with, a spirit guide, if you will, or it might be dabbling in essential oils and crystals. And, I've gone into so many different houses, and every single person's life is different. What surrounds their bed, what is hanging over their bed, what the feel of the room. Like, some people have scented candles, some people it's just very bare and barren. And again, it's trying to meet the needs and support whatever it is that the family has. So the holistic can be sort of not just the spiritual, but also what does this family need practically and emotionally in addition to the spiritual.
I was following up on the words comfort, Aimee, and I think Aimee has a related question, but before we get to that, it ties together the question of why so many people really look at getting off that medical merry-go-round. And a lot of it has to do with management of pain, the whole pain management aspect. So I know, Kelly, you were going to relay Mimi's comment, but I just wanted to maybe spend a little bit of time on the pain management aspect of hospice. And if there's support that's given to caregivers. Are caregivers usually guided or trained with regards to pain management?
Absolutely. When we talk about comfort, the comfort kit is usually, it's a box of medications that comes on admission, and usually it's stored in the refrigerator or a cool, dark place. And usually within a comfort kit, you'll have Haldol, morphine, Ativan, suppositories, stool softener suppositories, as well as Tylenol suppositories. You also might have Levsin, which is a secretion thinner, and also you have access to oxygen therapy. And those are just some like baseline, in addition to the liquid morphine. Those are some baseline medications, because generally what we're looking for at end of life is restlessness or agitation, pain, anxiety, shortness of breath, constipation, fever, those kinds of things. They're physical manifestations of what's happening in the dying process. All of them are expected. Not all of them occur, but and some disease processes have different symptoms that will be managed. Like people with respiratory symptoms obviously might be in need of oxygen therapy more so than somebody who maybe is having a dementia, if you will, because they might be otherwise healthy. It's just their brain is being affected. But I'm looking at I'm not sure, did I answer the question, Deb?
You did. I wanted to just bring up the whole issue of pain management, because that was one of the questions I had when my mother-in-law went into hospice. So I thought it might be something out there that before we now turn to maybe Mimi's point about pain management and morphine. So Kelly, I'll let you take that one.
So it sets up Mimi's question nicely. We found that we had to lead the patient-family discussions because more aggressive use of morphine was being advised for a person with a heart condition already, but who also had a slow-growing cancer. but otherwise in no pain. No alternatives were given, and of course the morphine use, despite the stool softener, caused problems with constipation. Are there better med cocktails, and how do we get, so that's kind of one question with that pain medication part of it, and then how do we get clergy to better prepare people, and how do we as caregivers better prepare people spiritually to ask for the sacraments and to ask for the advanced care directives and have conversations with our family and friends to ask for and give forgiveness, pass on their legacy. And then she said she's from the West Coast. We don't have much of that going on the West Coast, so we find it slow going.
Sure. There's a couple of issues. We'll just deal with them as they come up in your question. Regarding the use of morphine, there's a lot of misconception and misnomers about morphine use. First of all, there's a couple types. I'll just be very specific. There's, well, I'll say three. There's IV morphine. There's liquid morphine that you would ingest in your, under your tongue or in your cheek. And then there is oral morphine. Generally, the levels of morphine that are prescribed initially for hospice are considered pediatric doses. There is no, okay, let's give a terminal dose of morphine. That's not the way that hospice is designed to work. It's not about how can we end our loved one's life a little bit sooner. I've had plenty of people say, is there anything you can do to speed this up, because they're tired of waiting? So, and I mean, you understand the family's frustrated and people say things, and it's a very real issue, but it's not something that hospice does. Like there's no, we don't get medication levels high enough to be able to say, okay, let's just give her the whole bottle. It's just not, they don't dispense it in that high of an amount. Also too, like with the liquid morphine, usually what I see in the home is that we would be doing like 0.5 milliliters under the tongue initially. So that is just a little bit, and I'm not sure with your question, if the person was on oral pills, that can cause constipation, I think, a little bit more than the under the tongue morphine. So what I like to, I really like to use morphine with patients when I don't know whether it's pain or anxiety or agitation. Because if I can give somebody a little bit of morphine and I see them more comfortable, then I know we're getting somewhere. If I give them a little bit of morphine and Ativan, I feel good because I can see the change. You see the lines on their face start to relax. Their breathing is more even. They look more relaxed. They're not pacing as much. They're less restless, less agitated. And also too, morphine and oxygen for some patients can actually help in terms of shortness of breath. I know people tend to associate morphine with respiratory compromise, but when you give these small doses of sublingually, which means under your tongue, those can actually lead to so much more comfort, especially with people who have COPD or other kind of respiratory issues. Like anything else, you have to check with your doctor and whatnot. But I think if we could be more open about morphine and be willing to try it prior to it being a crisis. So with some of my patients, I would just go into the house and be talking to them and say, hey, it seems like you're having some pain and some anxiety. Do you want to try the morphine while I'm here? Okay. So they would try a little bit and be like, oh, wow, I had no idea. Like, I thought this would, I thought it would make me sick to my stomach, or I thought this. And you give people a lot of confidence, because what happens is if you try these in the middle of the night by yourself and you're home alone and it's 3 o'clock in the morning, your loved one's not breathing right, it's really difficult to get a comfort level with morphine and Ativan in the middle of the night. So anything you can do to try it earlier. Morphine isn't something, I had a woman who, she was in her mid 60s and she had lung cancer, and she just wanted to be able to go to the beach with her husband a couple of times on the weekend for the last few months of her life. She was up and walking around, but she had stage 4 cancer. And by giving herself the morphine and the Ativan every few hours, she was able to enjoy like maybe 2 more months down at the beach with her husband, and she was giving it to herself. So it's not something necessarily you have to be, your eyes closed, your death's door kind of thing to start the morphine. It can be something that can really improve someone's quality of life much, much earlier in the hospice process. And then to the next point is, how do we get clergy to be better prepared? I think that as church leaders, if we can organize like end of life seminars or conferences or whatnot, and we bring in speakers from the community, because you can imagine within your church or whichever group you're affiliated with, there's probably hospice professionals or medical professionals or legal professionals that would be happy to share their wisdom. I like to have a panel of people. So maybe you have an attorney, a financial person, a realtor, a home health aid, a home health company, hospice agency, maybe a local neurologist if they're interested. So I think that the more that we can get people talking about it, and especially if we can get them to come to the church and see the church as a resource, then all of a sudden it's like, okay, like, we think about churches with funerals, but we don't necessarily think about them with hospice, if that makes any sense. And the last point of that is, if you are a Catholic, and this actually would apply to any faith, if you want to organize like maybe like a healing night or a healing service where people from the community can come and be prayed over, or to just have their their concerns verbalized, that also too can be a great way to bring people into the church. And again, they don't have to be at death's door. This could just be somebody maybe who's having foot surgery next week. But again, you're getting people comfortable with, they're coming to the church when they're not feeling well. And it's not just to say, okay, I'm going to have, I need to set up my funeral. It's way, way, way before that, so that people feel comfortable talking about end of life before it becomes a crisis. Did that answer the question?
Thank you, Aimee. Maybe you can type something else in if need be. Another question from Luda is, how receptive is a primary care physician to the hospice appropriate question if none, or maybe just one or two of the criteria on your slide are actually present? Will this be seen as giving up, or that you want your loved one to die? Good question.
Yeah, I think it's a great question, Luda. Unfortunately, I think sometimes there's a little bit of tension in the medical community because doctors don't want to be seen as giving up on their patients. So as a family member, you think, well, of course my doctor's going to tell me when it's time for hospice. I'm not going to have to ask. And that's like the big secret, is nobody talks about it. It's just out there, and we're all sort of gliding along waiting for the other person to bring it up. So your primary care physician technically should be supportive of your question. They should say, well, tell me a little bit about why you think your mom or dad or sister or brother are qualified. What do you think, what symptoms do they have? And you can look online. I know that each hospice, they have their own criteria. There's general criteria that Medicare gives out. If you have these 10 things, or excuse me, if you have like 4 of these 8 criteria, then you qualify for hospice. So it's not a mystery. It's just based on your loved one's diagnosis. If you then search what, like for instance, COPD, like COPD hospice criteria, or heart failure hospice criteria, kidney failure hospice criteria, renal disease, like doesn't have to be actually be failure. So dementia hospice criteria. And once you see, like, for instance, with dementia, it's basically like if somebody's had a urinary tract infection or aspiration pneumonia in the last year, if they are unable to do most of their activities of daily living, like dressing, bathing, all that, a lot of time, most of the time, people are incontinent of both bowel and bladder at this point. That doesn't mean that people can't be walking around. Because as you know, dementia can be tricky. But I think that what I would do is educate myself on what the hospice criteria are for my loved one's specific diagnosis. And then I would contact my doctor, and try not to be discouraged if the doctor isn't receptive, because there's no reason to discourage people. They should be happy that you're advocating for your loved one.
Aimee, one more question from Bobby. Is there a resource you can point us to for specific what to expect or watch for in end-of-life situations?
I think if you go online, well, I know if you go online, I don't, off the top of my head, I can't say I have one source. I do know, though, that if you research hospices in your area, each of them, on their websites, they have different videos and they have different learning modalities, if you will, different slideshows. They might have some videos about end-stage symptoms, what to look for. I know people tend to think, unfortunately, because of Hollywood, like we think of end of life as very dramatic, like there's this, and then we crash to the bed kind of thing. The goal is to have a peaceful death. The goal is that this person is resting comfortably and quietly in their bed, and that it's more of a quieting. We're watching somebody sort of go from being this living, thriving adult to slowly, almost returning to the womb, if you will. And that ideally, as that person begins to quiet and we say our goodbyes, it's a very natural feel to it. It's hard to explain if you haven't seen it, but there's a beauty to it that it sort of dissipates the fear, and that once you can bear witness to it, a lot of people are surprised at how peaceful it is. They're pleasantly surprised because they thought it would be terrible and awful, and they were actually grateful that they were able to bear witness. I will say, though, that it's quite common that people who are very close with their loved ones, their loved one will wait for that person to leave the room or leave the house or leave the building, and then they will pass because they're doing it theoretically because they're protecting that person. So if you are caring for someone who's actively dying and you had to go to the bathroom or you had to go to the store or you had to take a nap and that person had passed while you weren't there, it's quite likely that that's a gift that they gave to you and that they just wanted you to have that one last moment of peace and that they're okay and that that's a gift that they leave you with, and that's not something to be ashamed of or to beat yourself up for.
And Aimee, just to follow on to that, in your experience, I would imagine that many family members and caregivers came to you as the hospice nurse and asked those very questions, and you were probably able to let them know sort of where their loved one was at in the journey, correct?
Right, and that's a good point, is that you're not alone in that when you're managing with your loved one. The hospice nurses can come every day if need be, or some of them have inpatient units if your loved one's symptoms are unmanaged and they can bring them in. They're available 24/7. They want you to call. And we always like to say, if you think about calling, call. Like if it even crosses your mind. Because what happens is it'll be, here's a classic example. It's Tuesday, 3:00 in the afternoon. Your loved one's having trouble breathing, but it passes. Wednesday, the same thing, but it passes. Thursday, things get really crazy. You're busy with work or the kids. You don't even notice. Friday night, things get really ugly. It's been happening all week, but we sort of put it out, and then all of a sudden our anxiety starts to percolate, and then we're faced with the weekend, and everyone gets afraid and thinks, oh my gosh, how are we going to get through this? So if you even have an inkling like, oh, it just doesn't feel right, or I just need a little bit of extra support, they want to hear from you. They absolutely want to hear from you.
Aimee, thank you. And for everyone out there, we're getting close to the end of our time, but Aimee has also said that she'd stick around for any additional questions that come in. But I think what we'd like to do now is transition back over. So Aimee, I'm going to go ahead and there we go. And while we're doing that, one of the things that I wanted to ask you, Aimee, as we're moving over here, is to look at how do people reach you, and can you talk just for a minute about, you mentioned you've got a practice, so how do families work with you, and what could they expect?
Well, you can always reach me via the website www.goodcaregiver.com. I actually wrote it down wrong. It's .net. But yeah, I mean, generally what I do is I meet with families and their loved ones, and we try and come up with a plan, whether it's they need help trying to find a way to keep their loved one at home, or maybe they need to go to assisted living or skilled nursing and they need help selecting the proper facility. They might need help trying to figure out, as somebody talked about, like getting all the siblings on the same page, or maybe mom has an issue but doesn't want to acknowledge it, and dad's really struggling, and you're trying to help support your dad in the decision. So I try and be like somebody that can provide some answers and options, so that to empower families to go forward and make their own decisions. I also like to think that I save a lot of money and time for people, because you could go into an attorney's office and pay $350 at least an hour, and they can hear your emotional concerns and they can hear your clinical questions, but they're going to be charging you for all of that. Mm-hmm. And if you can go to an attorney's office or your financial planner's office or your physician's office with a list of questions and a really solid game plan, you're going to leave there feeling a lot more confident, and they're actually going to have more, I don't want to say respect, but they're going to appreciate the fact that you did your homework, and they're probably going to give you more attention than the average person who just comes in and just, doesn't even know where to start. They can certainly help you, but it definitely will be more expensive and more time consuming.
Well, Aimee, thank you. And I'm sure you're seeing all the thank yous from everyone as they're wrapping up too. So thank you very, very much for sharing your wisdom with us. And as you'll notice, we have a couple more speakers coming up in July. Rick Hamlin will be speaking on prayer. He's from Guideposts. And then we move into Melissa will be talking on veterans and caregiving. And then Carlos will be speaking on caregiving and living in the present moment. So we have a very exciting lineup coming up in July. And then as we were talking about, there's resources available. So we would encourage you to stop at the Nourish for Caregiver website, where you'll find information about our Nourish for Caregiver ministry and additional resources and support, including some of those advanced directives and end-of-life issues, and then information on an upcoming book journal that's out, the Caregiver Companion. So again, thank you, Aimee, and thank you all for attending. Just thrilled to have you here.
And we hope to see you at more of these. And please let us know, send us notes to let us know if there's other topics that you feel we need to cover in future months. So thank you. Have a blessed night, everyone. And Aimee, thank you.
Thank you. It's my pleasure. Have a nice evening.
All right. Bye-bye.